Hello and a warm welcome to another edition of To The Point. On the show this week, Director General of Indian Council of Medical Research and someone who's been recently appointed as the Deputy Director General at World Health Organization. I welcome Soumya Swaminathan on To The Point.
Thank you.
We're going to discuss at length the state-level disease burden report, which your organization, in fact, has played a major role. What is the significance, what is the real significance of this report and coming out at this juncture?
This is something that we thought of 2 years ago. The reason is that so far all the statistics that come out on disease burden for the country basically talk about India and statistics for India. But we all know that India is a continent and it's made up of every state in India is like a country of Europe. So there's also a lot of variation and heterogeneity between the states in terms of health problems, health system performance. So I think every state really needs to know what is their local problem, what is their disease burden, and so that they can focus their policies onto that. So this is why we started working on this exercise. It's taken 2 years to really complete it. It's been a lot of hard work put in. But today what we've come out with is that for every state, we've got a disease profile. What are the top 10 causes of death and disability in that state? And what are the top risk factors for those conditions?
So would I be correct if I'm going to ask you that is it one of the reports of its own kind which has come out for the first time in terms of in-depth data analysis?
Yes, you can say that this is absolutely the first time that it's been done for India in such detail, in such in-depth and using so much of data sources. So we've really pulled together every type of health data that's been available to us. And we've used, because of the collaboration with the Institute of Health Metrics in Seattle and the Public Health Foundation of India, we've used the latest computational and modeling techniques to be able to do this. So these are as accurate as possible.
Dearth of data has always been a very big challenge in the health sector, and the policymakers have always cried foul that they've not been able to implement and bring in reforms in the health sector because of the lack of data. So now, what kind of a challenge does this disease burden report throw before the policymakers?
So you're absolutely right that data, accurate data is very important for any policymaker or health planner. And one of our limitations, I think, which we all need to recognize is the fact that we don't have a very complete and accurate civil registration system.
Okay.
What I mean is the birth and death registration, and particularly when somebody dies, in most countries there's a cause of death that's recorded according to a particular international classification called the ICD-10. It's the International Code of Diseases. Now, because that's incomplete in India, in fact, the latest analysis showed that we were pretty much at the bottom of all the countries as far as complete reporting is concerned. We have to make estimates and guesses and do modeling. So one thing we all need to do, especially the planners, is that we need to establish these systems of birth and death registration. The other thing is we've had a lot of surveys done in India. We have the NFHS surveys,
right.
We have the NSSO that's done, we have the SRS, which the Registrar General of India does.
Then you have something like an annual health survey.
We have an annual health survey which has now been discontinued. We've had the district health surveys for certain vulnerable districts. So we've pulled together all these different data sources and put them together in this analysis.
When you compare this disease burden report with the surveys which have come before, how are the two really going to differ in terms of maybe how the policymakers will take the road ahead?
If you take any of the other previous health surveys, they've been very specifically looking at something. Like the NFHS generally looks at maternal and child health parameters.
Right.
The SRS looks at the under 5 infant mortality and the maternal mortality.
Okay.
So they're all focused on different things. Now this survey actually tells us, or this burden estimation tells us the top 10 causes of death and disability in a state with data that's been compiled from different sources. And for the first time we also talk about risk factors. None of the other surveys has talked about risk factors.
So you mean to say that your parameter on which you have come out with the findings is much more exhaustive, is much larger?
It's much more exhaustive, and it uses a kind of metrics that can be easily compared with each other. We use a metric called the DALI. The DALI is the disability adjusted life years.
Right.
That means that if, for example, you have the potential to live to, let's say, 80 years, okay, but then you die at, let's say, 55, you've lost 25 years of life. Similarly, if there's some health problem you get and you're living with a disability, you're not living to your full potential,
Right.
then that's a disability. So either deaths or disability. So you add both of them, years of life lost and years of life lived with disability, and that gives you a number which you can then compare across countries, you can compare between states, you can compare in different ways.
So is this the number which you technically call epidemiological transition? Is that the number?
Yes, the number is used to define the epidemiological transition, but the transition really is moving from a situation where you have mainly communicable diseases and maternal and child health causes as the major causes of death, moving into an era today where we have non-communicable diseases like cardiovascular diseases and strokes and respiratory diseases and cancers being the leading causes of death.
Right.
And in some states like Kerala and Tamil Nadu, communicable and maternal and child health accounts for less than 20%
Right.
of the deaths. Of course, this is where we see variation. We see variation between the states which went to epidemiological transition way back in the 1980s, like Kerala and Tamil Nadu and Goa.
So if you talk about this report particularly, does India face a kind of a double whammy or a dual challenge of sorts, if I could ask you? Because on one hand, there are about 62% of the deaths which are on account of the non-communicable diseases, and then you also have the challenge because of the infectious diseases, the communicable diseases. So how does India tackle both the problems together, and is India, and are the Indian policy makers also not at crossroads?
So I think this has been a wake-up call actually, this report, because we've really now, you can see very clearly this double burden that you talk about. In fact, it's a triple burden, because we also have the third burden of injuries, which are both the unintentional injuries as well as the self-inflicted, the suicides, which actually are an important cause of death, especially among the youth, 15 to 29 years age group.
And in the earlier surveys, the injuries part has not been dealt with ever before.
It's been dealt with, but not in so much detail. So now we actually break it down into the different kinds of injuries. Like I said, the unintentional injuries, you have road traffic injuries, and then drownings, and then you have the suicides, which is an important component. So yes, we have still a burden of communicable diseases, more so in some states, what we call the empowered action group states of, the middle, UP, Bihar, Rajasthan, Chhattisgarh, Uttarakhand, Orissa, Madhya Pradesh. And then you have, but even these states are moving in the direction of non-communicable diseases. But we cannot forget about communicable diseases. They still play a big role.
But as far as the non-communicable diseases are concerned, of course, a lot of it has got to do with the kind of lifestyle which the people are leading. Urbanization, of course, is one of the major reasons. But why hasn't India not been able to respond to these kind of changes, despite the fact that you have policymakers who say, lots of things are being done on the ground?
That's an interesting question. The first thing we need to remember is that as populations live longer, so one thing that's come out very clearly is that between 1990 and 2016, the lifespan of Indians has increased by 10 years.
Right.
So we're living, the average lifespan today is 70. And so as you live longer, you are going to get more non-communicable diseases, because hypertension and cardiovascular diseases and all are diseases of older age groups. So that's to be expected actually.
Okay.
But what we have to focus on are the premature deaths. And like I said before, the DALIs. The DALIs per 100,000 population, if you compare a country like Japan or Sweden or even Sri Lanka and India, or if you compare India with the BRICS countries, China, we've got much higher rates of disease burden than these countries have. So we can do better. We can certainly do better. But one point I wanted to make, you mentioned infections earlier, and the infection that really stands out is tuberculosis.
Okay.
It's there among the top 6 leading causes of death in most states. There are very few states where it doesn't figure in the top 10. So even as we are talking about, development and non-communicable diseases and better living standards, we've still not really conquered this infectious killer, TB, which still kills about 500,000 people every year, Indians every year.
But don't you see this as a dichotomy as well? And why haven't the policymakers not been able to tackle the tuberculosis problem?
I think that the link with malnutrition is clear. Now, when you look at the risk factors that are causing all these diseases, today, even in 2016, malnutrition, especially women and children, comes out as a number one risk factor, accounting for 15% of the disease burden. It's come down. It was 30%, 35% in 1990. Today it's 15%, but it's still number one risk factor. And TB is very clearly linked to malnutrition and low immunity. So I think it shows that large parts of our population still have this type of low immunity. They're able to catch TB and spread it. And the other thing, of course, is that it is a disease of poverty. It's associated with many of the risk factors, overcrowded living conditions where it spreads much more easily.
Right.
People don't take the treatment as they should. And it's transmitted by air, so it's very easy for it to spread. But now I think there's a big commitment, there's a plan, a national strategic plan to really try and control TB or even eliminate it in the next 10 years.
But when you talk about the non-communicable diseases, of course, regular and moderate exercise, of course, holds the key, to tackle the problem. But what about things like urban planning, provision of open spaces? Does this report also not send out a signal to the urban planners or the Urban Development Ministry that look, a lot of it needs to be done in this sector as well?
That's an excellent point, because I think for non-communicable diseases, really, it's key that you have every sector of the government and non-government, civil society thinking about this. You mentioned urban development. You need pavements, you need parks, you need open spaces. In fact, there's a very interesting study that shows that people who live near green spaces have less depression than people who are living in overcrowded urban environments without any greenery around. Children need a place to go out and play. Otherwise, they're just stuck indoors watching television. The food processing industry is very important. We need to reduce the amount of sugar and salt that we're putting into our processed foods, because more and more people are eating packaged foods because of convenience. And we're taking a lot of hidden sugar and salt and fat from those foods. So the food processing industry needs to really look at ways of reducing sugar and salt. There's the Food and Civil Supplies Department, the Ministry of Agriculture. They need to promote more of whole grains, of millets, of pulses, of fresh fruits and vegetables, because our recent survey showed that 80% of Indians don't get enough fruit and vegetables in their diet as much as they should. And so we're eating mostly carbohydrate-based diet. So I think dietary, a healthy and balanced diet is extremely important. Exercise, as you mentioned, is extremely important. And then, of course, avoiding things like tobacco and alcohol. And the other big risk factor today is pollution, is environmental pollution, both outdoor pollution, and unfortunately in India, a large number of people still exposed to indoor air pollution, especially women who are cooking with solid fuel. This again is changing rapidly because of this Pradhan Mantri Ujjwal Yojana, where the LPG is being given to people under the poverty line. So in the last 2.5 years, I think something like 3 crore households have received an LPG connection. So hopefully we can phase out solid fuel, because that really causes a respiratory problem in women.
But when you're talking about the treatment of all these diseases, of course, everything boils down to the affordability. How much treatment can you actually afford? So do the policymakers from this particular report also start thinking about the health assurance schemes? Like for accountable care, terms like accountable care need to be incorporated as part of the policy making. How seriously will they do it? Because it's been for years, people have been saying that no, we are in for universal health care, we'll try and reach out to the people, but that's not been happening.
Yes, now we have to think at several levels. The first, I think, very important one is that we need to look at preventive healthcare much more seriously than what we've done in the past. Our healthcare system has basically focused on curative. Once you get a disease, you land up at the hospital, you get treatment for it.
Right.
Our primary health centers and sub-centers really need to become hubs of preventive and promotive healthcare, and that's what is being planned now. They are being renamed as a health and wellness centers, our sub-centers. So these centers can teach people about good nutrition, about exercise, about how to keep yourself healthy. Second is, as you said, the burden of diseases, cardiovascular disease, people having heart attacks, people getting stroke, getting cancer, getting chronic, these are all going to increase. Chronic kidney disease, and you need facilities to be able to offer treatment, because these are conditions which cause people to have these out-of-pocket health expenses, which then pushes them further into poverty. Somebody has a heart attack, or if you get cancer, then it's really a big financial shock for that family. So now states have started really thinking about how to provide these services to people at district hospital or at even lower. And some states have already started setting up centers to treat heart attacks, to treat strokes, at district hospitals. But we're still quite far away from being able to provide care. One thing that's happened recently is provision of dialysis at, again, district hospital. That's been a national program that's started. So at least people with kidney disease who need dialysis for years and years, they can get it free of cost in a government center. And these are being done through private-public partnerships. That's the model that's been adopted.
But what I would like to understand from you is that now, since this disease burden report has a large variation, it goes from one state to the other, and every state has a different data which has come up. Now, there was a perception that the Indian policymakers will probably come out with the health reforms, and it will be universally acceptable and applicable to the states. Now that since this report has come out with different data, so does that also send out a message that, look, every state needs to have a different policy. It has to be customized according to the respective states. Is it going to happen like that?
I think it has to happen like that, because otherwise this whole exercise is pointless. So I think now every state government is probably going to look at their report and say, okay, now for next year's planning, where do I need to allocate resources, and how do I really change my policies? So I think that needs to happen. And the other thing that needs to happen is the health assurance plan, or a universal health assurance program, which is actually being developed. A plan has been developed initially to cover just the below poverty line people, but then slowly cover the whole population like other countries have, so that you have a national health insurance program.
But how are you going to incorporate all this when India has a GDP spend of about 2.5% in health, and when you compare it with the global average, which is just about 6%, and the present government says that they're going to spend about 2.5% of the GDP till 2025. So which means that till that time, or during this period, how are you really going to expand the services, bring out the affordability, bring out the assurance schemes? How do you do that when you don't have money?
No, absolutely. I think you need resources. I think without resources, we won't be able to scale up many of these
things.
Does
that mean that you have a 2025 period which says that up till 2025 is going to be 2.5% of the GDP? So do we think of the plans being expanded and unfolded only after 2025, or the work begins from now on?
No, the work begins from now. So the plan is already there. So I think we need to see a progressive increase in health spending every year. That's the only way that things can get better. Today, we are only spending, the government is spending about 1.2, 1.3% of GDP. Overall spending on health is about 4% of GDP, but most of it is still coming from out of pocket, and only 25% is the government spend. Now, some states have started putting in their own resources. So that's another model now, with GST and all that, getting more resources to the states. It is also possible that states can start putting in more resources, especially for these health insurance programs. So I think if both states and center do that, we can see rapid progress.
So you mean to say that both the center and the state probably will have to converge somewhere as far as the policies and as far as the policies are concerned?
Yes. I think policies are more or less made in consultation, and they are uniform across the country. But the focus on one or the other, that has to be done at the state level. A state that has 80% of non-communicable diseases would naturally allocate more resources to management of those conditions, and a state which is still having a high maternal mortality or a high child mortality has to focus more on coverage, immunization coverage, making sure that pregnancy and births are safe, and so on. So we do see this variability, and therefore each state would need to make very informed decisions about how they're going to spend their resources.
I was going through this state level disease report, which one startling factor which I found, and probably if I'm wrong, you could correct me. I mean, of course, we are talking about all sorts of non-communicable diseases, the cardiovascular diseases, cancer, this, that. But the data on diabetes is really worrisome, which says that India has moved from 35th place to 13th, which is quite a jump. And how do you explain, and how do you actually go for a targeted intervention as far as diabetes is concerned?
Yes, diabetes and hypertension, I think both are of great concern. And in fact, recently the ICMR had done an independent study called the INDIAB study, which looked at state level diabetes prevalence. And what we found is that it ranges from, anywhere from 5%, which is a low still in the northeastern states and states like Chhattisgarh and Jharkhand, to a high of 15% in Punjab and Tamil Nadu and Kerala. And the equal number of people with pre-diabetes. That means they're just waiting to get into diabetes. This has happened over the last 20, 30 years, probably because of, again, improvement in living standards, changes in the dietary pattern, reducing physical activity, increasing obesity, abdominal, especially, Indians tend to put on weight around their tummies, which is abdominal obesity, and that really leads to diabetes. It's going, and it's true for urban areas, for rural areas, and a very startling finding is that it's affecting the poor. We always think of diabetes as some disease of people who have enough resources, but no, it's affecting the poor both in urban and rural areas. It's affecting tribal populations, and there's probably a genetic predisposition that Indians have to diabetes. That plus the sudden change in our lifestyle, I think, has led to this very dramatic increase, and we have to do everything we can to slow this down, to reduce, to prevent, and also to make sure that people who've already got diabetes take treatment, because the complications of diabetes are very bad, and the only way is to keep your blood sugar under control to prevent these complications like kidney disease and nerve problems, eye problems, heart attacks.
But now at this particular juncture, if you have to take a wholesome approach towards health and taking this particular disease burden report, the state's disease burden report as a starting point, if I may call, how do you go about? Now, for example, the biggest challenge is the health infrastructure in terms of both human and physical. How do you deal with that at this point of time?
Again, there is a plan to deal with that. So I think the plan needs to be implemented, and it will need resources. It's going to need additional budget allocations. So two things. One is physical infrastructure of the primary health centers and the sub-centers needs to be looked at. But I think even more important is the human resources, the people who are going to man these places. So right now the plan is that at the sub-center, which caters to about 5,000 people, you have either an Ayush practitioner or you have a nurse practitioner, somebody who's trained, a nurse who then does a bridge course, so is able to treat most of the common diseases which present at that level. And then of course the referral system, you have the primary health center, and then you have the community health center and the district hospital. But having people who are trained and who can handle these things, having also basic equipments, basic diagnostic facilities available, and drugs. I think so free diagnosis and free drugs is what is very important to be able to keep people, especially for chronic diseases. It's okay if you're going to have a pneumonia 5 days, you take antibiotics, you're okay. But if you have diabetes or hypertension, you have to take medicines all your life. And unless that's available to you near your home, it's convenient, you have somebody who can counsel you and explain and also check your BP once in a while, and then tell you if something's going wrong, that you better go see your doctor. That's a type of model now which we don't have currently in the country.
Of course, the quality of doctors, of course, is a very big challenge. Now, for example, in Jharkhand, where we were reading that the malaria patients were given saline drips. So it's like, this whole concept of quackery and crookery both at the same time, which exists in the health system. How do you do away with that? Are you going to do away with that only with the help of the legislations. Then of course when you talk about legislations, not enough implementation is happening. So of course somewhere down the line then the quality gets impacted.
So yes, unfortunately large parts of our country, the quacks are the ones who, or the unqualified practitioners or whatever you call them, are the ones who are providing the first point of care. So I think the only way to handle that is for the government health system to really start providing high quality care, and then automatically there won't be a need for quacks. People will go to their sub-centers and to their primary health centers if they find that there's always somebody there who's able to respond to the problem, and there are drugs available and diagnostics. So once that happens, I think there'll be a complete shift. So the focus should be on making sure that we're able to provide the quality care, and the quacks them automatically will disappear. But till that happens, they are the ones who are available in the community and at a minute's notice. And so, that they are the first people that the point of care for most people, and they misuse antibiotics, they misuse a lot of drugs because they're not trained.
Quoting you exactly your phrase, what you used in the beginning of the interview, when you said that this disease burden report, the state disease burden report, is actually a wake-up call. Now, if I were to ask you, you're representing an organization which is autonomous. At the same time, you're representing the government side of it. When you talk about the health challenges, we've seen that the political parties, be it the ruling parties or the opposition parties, health doesn't become a part of the natural discourse in the country. Why is that so? And why can't organizations like yours change this narrative?
That's an interesting question. I think, we have been trying to change that narrative, and I think shows like this, there need to be many more discussions, I think, within the media on the health problems of our country. It's happening. I see a change now. There's much more interest. And making it in a way that's understandable and make it interesting for people to really read and know more about their own health. I think health literacy in India is low. People do not know enough about how to stay healthy and what the problems are, which is why they also get exploited by quacks. But the other thing is, yes, I think one has to, an organization like the ICMR is there to basically bring out the facts, bring out the evidence, and be very science-based. Be honest and open about what is really happening, because I think the first step is really to accept the problem, understand the problem, and then only we can try to address it. So that is what we hope that this disease burden report would do. It's not to name and shame anybody or to bring disrepute. In fact, there are a lot of things which have happened good in the last 25 years when you see the report. A lot of improvements have happened. But it's again a reality check.
The way it has responded to sanitation.
Yes, exactly. Water and sanitation, life expectancy is increased. We've gotten rid of polio, and tetanus. Immunization coverage has gone up. So lot of things have happened. But then what's the road ahead? I think that's what we really need to look at. And that, I think, is now there for us to see and respond to.
And I'm sure now that you will be representing India at WHO, and I think you're joining on 1st December.
Yes.
So you'll make the voice of India more heard at the global platform.
Let's hope so.
Wish you all the best.
Thank you very much.
So that's it on this episode of To The Point. See you next time with another personality. Goodbye and thanks for watching.